Let me just sort of by way of introduction say, I really wanted to talk to you about two of your particularly successful aspects of your kidney supportive care program. One is the conservative kidney management program, and then the other is the way that you really sort of pioneered improving pain and symptom assessment and management for your patients. If we can start with your conservative kidney management program, and by the way, our patient advisors in this country really prefer that we call it active medical management without dialysis. They don't want to feel like it's a minimal type of thing, which conservative care often sounds like. And I was just talking to a nephrologist yesterday who says, I call it maximal medical management without dialysis, to emphasize that we really are doing something. It's just for a different goal. But at any rate, if you had to say, what were the three things that really enabled you to build a strong conservative kidney management program, what were they?
I think right out of the gate, the most important thing starting this work was extensive stakeholder engagement. So it was even before we put a proposal together, we had to get together all the end users of what a pathway might look like. So it was the patients, the families, the frontline staff, the multidisciplinary teams. And we really needed to identify what their needs were. So at the end of the day, we were addressing these needs. So we were putting forward a proposal that there was pull for, there was frontline, it was driven by frontline needs. So it wasn't an initiative that was being pushed onto them in a system that's already burdened, and they had a lot of behavioral change fatigue. So it was really that extensive stakeholder engagement right out of the gate. I think the next thing was really our co-design philosophy. While I had a vision of maybe what this pathway might look like, for it to be successful, it had to meet the needs of everybody. So not just the patients and their families and their caregivers, but every member of the multidisciplinary team. And that's not just the nephrologists and our care providers. It was primary care, home care. It needed to be something where we could all come together. And I didn't necessarily know what the barriers and facilitators of that care was. So that co-design process was critical in ensuring that all design or all stakeholder needs were met for sustainable uptake of the pathway. And we ended up identifying so many pieces of the pathway that if it just been myself and my research team, we would have missed it. The patients have a very complex trajectory and pathway in terms of where they come into the health system, and all of that needed to be captured. And then I think the third major lesson in implementation was really around the implementation. It needed to be facilitated. They needed extensive coaching and practice facilitation, especially around the first 18 to 24 months after we went live. And they needed ongoing real-time audit and feedback. So when we were implementing, we would say to them, what do you most want to achieve out of this implementation? And they would pick those key indicators that were really important to them. This is the reason why they were doing this in the first place. We would monitor those and give them the metrics to see if they were achieving or not. And if they weren't, we helped them design their own action plans. It had to be flexible for every center, because every center had different expertise and resources. But allowing them to develop their own metrics, helping them develop their own action plans, and giving them the real-time audit and feedback. I think that was critical, and that needed to happen for about first 18 to 24 months. So really out of the gate, they were probably the three top things that I think allowed us to be successful.
And when you talk about they, are you talking about each region or each local area developing what worked best for them?
Yes, so this was after the co-design process. It wasn't just enough now we had this great interactive tool and pathway. We had to actually help facilitate the process of implementing it within their day-to-day workflow. And that had to be adaptable and flexible to local context. And we really needed to help them and coach them through that, and then see, were they achieving what they wanted to do. Were patient outcomes improving? If they wanted to improve, were symptom screening, was it being done? Were symptoms actually improving? Were they actually doing ACP? Were conversations happening? Did patients have a crisis plan? If this was what was important pieces of the pathway, they needed that audit and feedback to actually say, okay, well, we wanted a target of 80% of patients for getting this. We're only at 50. Why is that? And we would help them walk through where were the barriers in that. So really having a great tool that they co-design is not enough. You have to help them implement right through the actual workflow on site, and that really was important.
It sounds to me like you had quality measures and you were collecting data on maybe a monthly basis that was coming to you centrally and you were feeding it back to them. Am I correct?
Absolutely. It was real time, and we had monthly reports. Some things were only updated every 3 months, but the things that were captured on a monthly basis, we put reports out every month. And it's an active tableau, so they could actually go on and look at any time to see how they were performing.
Have you published that, or is that available on your website, the monthly measures you were collecting?
No. So the monthly measures, we've got snapshots of the tableau, and I've presented it many times at international conferences. The publication on our results will be, we're just actually in the process of finally writing it up. Results are all out, so we do have the evaluation complete.
Right. One of the issues that's been particularly a problem in the United States is what we call nephrologist buy-in. And you may have read, in fact, I know you've written an editorial about it, you may have read that really that is one of the things that's held back the implementation of kidney supportive care. And we've even learned with some studies that have been done that only about a third of nephrologists really believe in what you call conservative kidney management. Where are you with Canadian nephrologists?
I truly believe that the majority of Canadian nephrologists see and support the need for conservative kidney management, and they do view it as a viable treatment modality. Now, having said that, that's not to say that all Canadian nephrologists, or even the majority of Canadian nephrologists, feel comfortable delivering that care. So we have pockets of expertise across the country where they're very comfortable with conservative kidney management, but we have many centers where they have yet to formalize a CKM, a conservative kidney management program, but they are committed to trying to move that forward and formally integrate that care into their kidney programs. The question is, not every center really understands how best to do it. So I think the willingness is absolutely there, and they're actively looking for solutions. So at a national level, we now have a national working group that is working towards developing a national CKM toolkit. And this toolkit is really looking at not just getting national consensus on what the core components of CKM are, the guidelines, all of that obviously is critical, but it's about what are the resources that you need? What are those implementation strategies? How do we do it? And when we do it, what are the evaluation frameworks around it that our program can grow, evolve, and continue to meet the needs of patients?
So I want to, if I can unpack this a little bit, so you don't have this in every single region, it sounds like, or every single place.
No.
Where it is occurring, does the nephrologist lead the conversation? Does a nurse practitioner? Does a social worker? How do patients learn that there is this non-dialysis option?
Yeah, so I think in many of Canadian centers, and this is different across the province, across the country, obviously, but many of our advanced kidney clinics are really nurse-run. They're run by these fabulous nurses that have quite extensive experience and a really good scope of practice. They lead many of the aspects of care. I think what's most important having these conversations is that it's the individual that has the most expertise in the area. And really, it's everybody's responsibility. Social workers can address some of the issues, nursing staff can address some of the issues, but at the end of the day, if the nephrologist is not involved, I think that can be problematic. The patients do expect the physician, even if they're not leading that conversation, to be supportive of that conversation and to be part of that conversation. But I think in our program, where our nephrologists do have the conversation, they're not necessarily already always leading it. Many of the nursing staff will have already initiated the conversation. We've got our interactive patient decision aid, and that was really developed at the need of the nursing staff to help patients walk through this conversation. So our nephrologist might use it, but it was really designed because the nursing staff had said, we want more support facilitating these conversations. So I think in our program, we really share the responsibility, but I feel that the nursing staff carry a substantial weight of at least initiating that discussion.
So in a conversation that I had with Mark Brown, we were talking about 5 things that his program has sort of looks at. They look at age over 75. They look at comorbidities. They look at frailty. They look at nutritional status. They look at cognitive status. And even the surprise question, would they be surprised that the patient died in the next 6 months or not? What things are you teaching your nurses to be able to identify patients that it would be appropriate to present this non-dialysis option to?
Yeah, so I think they will have done lots of clinics with a nephrologist to begin with. So they already have a sense of those patients who are likely appropriate. But our CKM patient decision aid really walks them through things in a very systematic manner. And there are about 5 prognostic indicators. Again, it's age, whether they're in their 60s, 70s, or 80s. It's their living circumstances. So we know those patients who are already in a nursing home tend not to do as well. We look at their cognitive function, we look at their physical function, and we also look at their comorbidity mix. They're the 5 things. We have the influence, but then they walk through all those other things that are important to patients as well. How important is it for you to travel, have control of your life, or avoid hospitalizations, or whatever it is that's important to the patient. They will then walk through those things in a very systematic manner as well. So our nursing staff are really taught modality teaching. That is a key role of the nursing staff in these advanced kidney failure clinics. So they're taught the benefits of hemo, peritoneal dialysis, of transplantation, and conservative kidney management. And they really have to be able to explain all of those options in a very balanced manner. And then obviously the nephrologist is part of that multidisciplinary team. It's not like they're doing this in isolation.
What if you had to name what is the biggest challenge you faced with your CKM program, what would you say?
And then I think the biggest challenge though moving forward is sustainability. So eventually you transition to operations, and I'm not there in all the clinics making sure they're doing what they need to do. So for sustainability, we had to put in very visible, ongoing quality improvement. So those metrics now, they're part of the program's quarterly reporting. That doesn't change. So just because I'm not checking in on them every month, upper management and their bosses are. So that ongoing feedback and quality improvement metrics evaluation is critical, and also developing educational modules for staff. There's a lot of turnover in our clinics, so we had to make sure that as new staff come on, the training for CKM is fully entrenched in everything that they get. They get training about complications of CKD, they get training about a lot of things, but now they're trained on symptom management, how to have those conversations. They're trained on the patient decision aid for CKM, but we had to fundamentally put that into our program's training for sustainability.
Okay, that's helpful. I'm just going to ask you two more questions about your CKM program, and then I am going to specifically ask you about pain and symptom assessment and management. So when I talked to Mark Brown in Australia, he's had 300 patients in his renal supportive care program who have not started dialysis. And he said of the 300, only 3 at the last moment changed their mind and started dialysis. So that's 1%. When I talk to nephrologists in the United States, almost every patient that started in a medical management without dialysis pathway ends up starting dialysis. What's your experience in Canada?
So I think we need to understand first what the uptake of conservative care is to put it in context. So prior to our pathway going live in 2016, if we looked at patients over the age of 75, for the several years prior to it, the annual uptake of conservative kidney management was about 11 to 14%. With the uptake of our pathway now, we are now up to 34% of our patients aged 75 years of age or older are choosing conservative kidney management. Despite that, they are satisfied with their care and they do not change their minds. Now, I can't say we're at 1%, we're not. We're probably closer to 3 to 4%. But I think what I really, really want to emphasize is flexibility is critical, and it's that shared decision making, and you need to have ongoing shared decision making to make sure care remains aligned with patients' preferences. So if you're caring for them really well and some remain quite stable, their cognition, their function, their symptom burden, and they end up doing better than they or you thought they were going to do, it is quite reasonable for them to change their mind. That is not a failure of your program. What is a failure of a program is when you have something like an acute symptom crisis that is not adequately managed. They end up in the emergency room and they start dialysis when their underlying values and preferences hadn't changed. And that we are not seeing. We have not had any of that since 2016. We haven't had a single ICU admission of a CKM patient. So we consider that quite successful. So even though 3 to 4% of patients have changed their mind, most of them don't actually start dialysis. Half of those will probably die before the need for dialysis. We've only had a couple that have actually truly started dialysis.
So how do you prevent that acute symptom crisis that leads to an emergency department visit and emergency dialysis?
That probably takes up half of our pathway. It's all those community supports and everything that has to be put in place. So it starts off with end-of-life care planning. You have to understand what your patient's preferences are. So they need to understand what can they expect for symptom burden, what will it look like, and once they understand that, we need to understand what their preferences are. Where do they want to die? Home versus a hospice versus another care facility. Who do they have involved in their care? What are their resources? And when we understand that, we put a plan in place. It has to be coordinated with their primary care physician. We need to hook them up with home care, probably, potentially home palliative care. All of that needs to be put in place. The other thing that has to be put in place is their advanced care planning documentation. And we have a specific sticker that goes on their goals of care designation that says CKM, conservative management without dialysis. It's a big sticker on their green sleeve, lives on their fridge. And so our paramedics are trained to look for that and then to try and treat them at home. But we know despite all of this planning, it sometimes happens. So we have crisis management plans that are done on all patients, and they go into their care plan in their green sleeve. So they're taught what are the most likely symptoms that could precipitate. How do we treat them? We have anticipatory prescribing, and we have a little cheat sheet for the physicians, for the family physician, for home care, EMS, and the emergency room physician. If they present with these symptoms, including shortness of breath, they're not to have dialysis. This is the pathway they're on. These are the things that you need to do. So we have that crisis plan that's negotiated, and everyone is aware of it. And so far we've been successful.
And what else do you think has been key to the success of your CKM program? Is there something else we should discuss, or something else that you know is
No, I think what's really critical, Woody, is that as programs move forward, everyone has to understand it's a shared responsibility from the multidisciplinary team to have an effective conservative kidney management program. Everyone has to buy in. They all have to roll up their sleeves. Everyone has a role, and it's not sufficient just to rely on your kidney care teams. These patients transition through multiple parts of the healthcare system. It has to be integrated into the primary care and community care services. So if without that integration, the patient's going to fall through the gaps at some point. So that is really critical. It's working with your primary care colleagues